Hello, everyone. My name is Lucy Schiffman, and I'm the Senior Manager of Community Engagement for the Myotonic Dystrophy Foundation. I'm so excited to welcome you today to our Ask the Expert webinar, Seeing DM Clearly and Understanding and Managing Vision Challenges. Before we begin, I want to share a little bit about the Myotonic Dystrophy Foundation. We envision a world with treatments and a cure for myotonic dystrophy. Our mission is made up of three components: community, care, and a cure. We support and connect the myotonic dystrophy community. We provide resources and advocate for care, and we accelerate research towards treatments and a cure. MDF is here to support you. We have a variety of resources on our website that are dedicated to supporting those living with myotonic dystrophy and their families. You can find our toolkits and publications, which include resources for care providers and families, including the DM in the Heart Community Guide, Anesthesia Guidelines, our MDF Toolkit, Mental Health Guide, Clinical Care Recommendations, as well as resources for clinicians and researchers, including grant funding opportunities for DM research. We also have a variety of support groups that are led by trained community volunteers. Our support programs create safe spaces to network, learn, and share. Online, you'll find our digital academy where you can view hours and hours of educational and inspirational videos by DM experts on demand. And lastly, you can find our calendar events where you can learn about all of our upcoming support groups, conferences, webinars, and more. Find all of these and more at www.myotonic.org. We want you to stay in touch, so we encourage you to follow us on social media to make sure you're up to date on all things MDF and DM. You can find MDF on Instagram, X, Facebook, and LinkedIn. You can also sign up for emails at www.myotonic.org/sign-up. I want to highlight a few of our events that are coming up. MDF will host a Meet the Drug Developer webinar on August 1st, next Friday, with Artex Biotech. Register today to participate. We also will be hosting future Ask the Expert webinars. In August, there will be one on genetics and DM, and in September, pediatric endocrinology. If you are registered for today's Ask the Expert webinar, you don't need to register for other webinars. By registering for today's, you registered for the entire series. If you're watching the recording and would like to register for our upcoming webinars, you can do so on MDF's website. You can also increase understanding of myotonic dystrophy and improve the lives of those living with DM by joining the Myotonic Dystrophy Family Registry. The registry helped inform MDF's topic selection of today's webinar on vision and DM. 30% of registry respondents report trouble with vision due to cataracts. The registry gives all DM stakeholders, from researchers and pharmaceutical partners to family members, a better understanding of the disease, the DM community, and current research and advocacy efforts. Join or update your listing today. I want to take a moment now to thank our sponsors for the Ask the Expert series, Avidity Biosciences and Dyne Therapeutics, for sponsoring this Ask the Expert webinar and the rest in the series. Now, I would like to thank all of you for joining us today from around the world. Today's program will be an Ask the Expert webinar, which will feature a presentation from Dr. Vinod Mootha, followed by time for a Q&A. We ask that you use the Q&A function to ask your questions. They will be sent directly to our speaker. We will do our best to answer as many questions as we can during this webinar. To ask questions, click the Q&A button on your Zoom screen and type your question into the text field and click send. You can send questions anonymously if that's your preference. Without further ado, I'm pleased to introduce Dr. Mootha. Vinod Mootha is a professor in the Department of Ophthalmology at UT Southwestern Medical Center. He earned his medical degree at Johns Hopkins University School of Medicine and completed a residency in ophthalmology at the University of Wisconsin. He then received advanced training in treating corneal and external eye disease and performing keratorefractive surgery through a fellowship at UT Southwestern Medical Center. Certified by the American Board of Ophthalmology, he joined the UT Southwestern faculty in 2004. Dr. Mootha has delivered scores of national and international presentations, served as a principal investigator for several National Institutes of Health-funded research projects, and published numerous academic articles on corneal transplantation and Fuchs endothelial corneal dystrophy. I will now turn the time over to Dr. Mootha.
Well, thank you so much, Lucy, for that kind introduction. As Lucy had mentioned, I'm an ophthalmologist. I'm a corneal specialist, and I do cataract surgery here at UT Southwestern Medical Center in Dallas. I was recruited to Dallas about 20 years ago. And over that time period, I developed an interest in human genetics because I saw a lot of patients and family members with this age-related corneal disease called Fuchs dystrophy. And we'll get to that topic during my webinar, but that's how my interest in human genetics developed. I'm quite honored to be presenting to the Myotonic Dystrophy Foundation today. My initial first opportunity to learn more about this organization was 2 years ago. It was a great honor to go to Washington, D.C. and participate in the meeting there. And I was so much impressed by the patients, their family members, this entire organization, in the way you advocate for better treatments and educate the field, not only amongst patients, but also scientists and researchers about myotonic dystrophy. So it is a great honor to be participating in this webinar. So I thank Emily Romney and the organizers of this webinar for this opportunity. As this audience well knows, myotonic dystrophy, it's a multisystemic disease, and it affects primarily the skeletal and smooth muscle, but it impacts many organ systems throughout the body, including the heart, endocrine system, GI system, central nervous system, and the eye. And we'll focus this webinar on how I would approach the different eye manifestations of myotonic dystrophy and how I would go about advising my patients. So it's going to be very much a clinical talk geared towards those topics. As this group well knows, there are two main forms of myotonic dystrophy. Myotonic dystrophy type 1, which is also known as Steinert's disease. It's ironic that this entity goes by Steinert because Steinert was one of the great legends in ophthalmology. He developed a technique called phacoemulsification, which is the primary method that we remove cataracts. So it's kind of ironic that myotonic dystrophy type 1 also goes by this name, Steinert's disease. So myotonic dystrophy type 1, it's caused by a trinucleotide repeat in the DMPK gene. Whereas myotonic dystrophy type 2 is a repeat, CCTG repeat in another gene called CNPB. But both can affect the eye. So I'd like to start with a basic primer on the anatomy of the eye. The cornea is the clear tissue in the front of the eye. It should be transparent. It's very important because it lets light into the eye, and it's also the major refractive component in the eye, meaning it bends the light rays such that it's focused. The light rays are focused on the retina. So behind the cornea is the iris, and the central opening in the iris is the pupil. And behind the pupil is the lens. The lens is also very important in terms of bending light rays such that the light is crisply focused on the macula, the central part of the retina. And then you see how the optic nerve will convert the light energy to electrical impulses to the brain. But there are important muscle structures not only within the eye, but also around the eye in the form of extraocular muscles, which move the eye. And there are muscles, skeletal muscles that impact or control how the lid closes and the positioning of the eyelid and the brow. So myotonic dystrophy can affect any of these structures, but let's start with how the muscles of the eye, eyelids, and the brow can be affected. So there are extraocular muscles that move one's eye. And because of myotonic dystrophy, these eye muscles can be weak. And in some patients, there's a condition called ophthalmoplegia, which limits a patient's ability to move their eyes in various fields of gaze. Another rare manifestation of myotonic dystrophy in terms of its involvement of the extraocular muscles is abnormalities in saccades. Saccades are rapid eye movements. We ask our patients to look left and right really rapidly to assess their horizontal saccades. And on occasion, these rapid eye movements have been affected in patients with myotonic dystrophy. And that may be a result of the myotonia that can affect skeletal muscles in patients with myotonic dystrophy. The brow can become droopy. That is because of weakness of the frontalis muscle. But I think the more significant muscle that can be affected is the levator muscle that can result in a droopy eyelid. And depicted on the right is a gentleman that has myotonic dystrophy. His brows are probably a little lower than normal, and you can see how his upper lids are droopy. Some of these changes one can see in normal individuals as we age, but in myotonic dystrophy, these changes are thought to be myogenic in nature, meaning the muscles are abnormal and contributing in the brow being droopy and the eyelids being droopy. Here's another patient with ptosis. Here it's a little bit more subtle. This is a younger individual, and you can see how the light reflexes touch the upper lid margin. In a patient without ptosis, the eyelid should be a little higher, such that there's a little bit of a gap between the light reflex on the pupil and the margin of the eyelid. This patient doesn't have any significant brow ptosis, though. This patient just has mild ptosis or just droopiness of the upper lids. This is a patient that I saw recently in my clinic with myotonic dystrophy. And I would say that they had mild ptosis or just mild droopiness of the upper eyelid. And this yellow stain that's on the tear film, I use that in all my patients to examine their corneal surfaces. This stain called fluorescein is very useful to detect dry eye. And patients with myotonic dystrophy may have some component of dry eye. And this hasn't been extensively studied in our field, to be honest. We need to learn more about the dry eye that may occur in patients with myotonic dystrophy. But it may be related to perhaps an incomplete blink or a lower blink rate. These factors may be contributing. Because of these potential corneal changes in terms of dry eye, I would be conservative about advocating for patients to have surgical correction of ptosis or their droopy eyelids. So I think one should be conservative as not to avoid corneal exposure or drying out the cornea after having eyelids raised. That is a potential side effect of the surgery. So patients with myotonic dystrophy have been reported to have small pupils. So there's a cartoon diagram in the right. The pupil is the aperture. Basically, it's the opening in the iris that lets light in. And the iris has both muscles that constrict as well as dilate the pupil margin. And it's thought that abnormalities in the smooth muscle function may result in slightly smaller pupils. This usually is not of any visual significance and should not contribute to any problems, though, in terms of the patient's vision. Patients with myotonic dystrophy, because of these pupillar abnormalities, their eyes may not dilate as well. Those of you that go to your eye exam may recall getting eye drops for dilation so that your eye doctor can check the structures behind the pupil, namely the lens and the retina. Patients with myotonic dystrophy may not dilate quite as well. Here's a photo of someone that has had the dilating drops, but that don't dilate quite as well as other individuals. And in the bottom, you're seeing the dilated exam of the lens, which is the part of the eye that can get cloudy, and that's called a cataract. Patients with myotonic dystrophy also have been reported to have slightly lower eye pressures than in normal eyes. And there's a part of the eye called the ciliary body, and there's that turquoise blue arrow on the bottom pointing to the structure. This structure has both muscle as well as epithelium, and this structure produces the aqueous humor. That's the liquid in the front of the eye that circulates from its production, the ciliary body, and it goes behind the iris in front of the lens to the front of the pupil, and it's drained out. So this aqueous, there's turnover, and it's this aqueous that gives the eye its pressure. And some of you may have relatives that have developed glaucoma. That's a condition where the eye pressure is high. But in patients with myotonic dystrophy, their pressures are approximately 25% lower than in normal individuals. So it's the opposite issue. Their intraocular pressure is low. And it's thought perhaps that the ciliary body may be detached in some individuals, resulting in this phenomenon. Now, all medical students, residents in ophthalmology are taught that there's a pathognomonic form of cataracts called Christmas tree cataracts. And you've heard this term. It's a very peculiar type of cataracts that we don't see often in conditions other than myotonic dystrophy. But generally speaking, cataracts are the most common eye finding in myotonic dystrophy types 1 and 2. And a cataract is when the lens inside of the eye gets cloudy. And I tell my patients, regardless of whether or not they have any systemic disorders, including myotonic dystrophy, if we live long enough, all of us will develop a cataract. And at some point, the cataract may reach a point where it starts impacting your quality of vision. And that's the time point for you to have a discussion with your ophthalmologist about potentially considering cataract surgery. But in patients with myotonic dystrophy, the cataracts are thought to be early onset, namely the cataracts onset may be between the ages of 30 and 40. And, that's a decade or two earlier than the typical age-related cataracts that we see routinely in our practice. I'd say the median age of cataract surgery is probably 60 or above in my practice. So patients, probably myotonic dystrophy patients in their 30s and 40s, they should be getting annual eye examinations, and this phenomenon of cataract formation can be monitored. Apart from the Christmas tree cataract, which is illustrated in the photograph in the right, another type of cataract called the posterior subcapsular cataract can develop. That affects the innermost layer of the lens, and we call them PSC cataracts, or posterior subcapsular cataracts. And they are notorious for causing problems with reading and also glare with headlights and street lights. So patients with posterior subcapsular cataracts, it's their reading and driving that may be initially impacted. So once your eyes are dilated, your ophthalmologist can take a really good look at the lens, which is the structure that sits behind the pupil. So this is that patient that I saw recently in my clinic that had a diagnosis of myotonic dystrophy type 1. They had genetic testing, and they were aware of their diagnosis before presenting to me. So this is a slit lamp photo. So that's that binocular microscope that is used to examine the structures of the eye. And this patient had been dilated. He didn't have your classic Christmas tree cataract, but the subsequent photos will show the types of cataractus changes that this patient had. So we're able to use this slit lamp. We are able to use it as a narrow light beam source, and we're able to look at structures in both the front and the back of the eye. So that first light reflex on the left, the light is being reflected off the cornea. But to the right is the lens and the changes in the lens that I'd like to highlight that can be seen in patients with myotonic dystrophy. You might just be able to see some specks there towards the right-hand side of the photo that shows the cataractus change. Here, I'm trying to focus the light towards that posterior lens capsule. This patient had a posterior subcapsular cataract. It may be hard for a non-ophthalmologist to appreciate, but I'm trying to focus through the lens, and on the right, I'm focused on the posterior lens capsule. So this patient had both iridescent kind of colorful specks throughout the lens, and also had this posterior subcapsular cataract. Here, I'm just showing you some of the flecks on the surface of the cornea. I think this photo and the next. And these changes are hard to photograph. So I apologize if the changes aren't quite as clear as the Christmas tree cataract that I showed you initially. These are the specks that you can see, these iridescent punctate opacities. And some of them are colorful, you know, they're like little crystalline, like little Christmas tree lights. So they're different colors that make them a little bit more peculiar. And then there are just some tiny specks that were red and green and blue in this patient that gave you a hint that this patient had an underlying diagnosis of myotonic dystrophy. Once again, the subtle changes. The main points I'm trying to make here is that myotonic dystrophy patients develop cataracts. A subset will have that classic Christmas tree cataracts that are so famous, but a lot of them will have posterior subcapsular cataracts, which can be seen in many other entities, or in either patients that are diabetic, or patients that have been on prednisone, or even patients that develop cataracts as part of aging. The posterior subcapsular cataracts can develop. But the colorful specks within the substance of the lens, that is specific for patients with myotonic dystrophy. So here are more of the specs. So it may be hard to make a diagnosis of myotonic dystrophy by examining the eye or the changes of cataract, unless they have that marked pattern that we refer to as Christmas tree pattern. So I'm a very conservative cataract surgeon. I'd like to think I'm as good as any cataract surgeon, having done cataract surgery for the last 30 years. I tell my patients I've done thousands of cataract surgeries over the years. You know, it's really important for you to assess for yourself, though, how you're doing in terms of your quality of vision. You know, if you're having problems with your reading or driving, and we see enough changes in the lens that could corroborate or support your visual complaints, that's the time when I start having a discussion with my patients about cataract surgeries. And I tell my patients that even in the most experienced of hands, there's about a 1% risk of complications, damage to the front of the eye, the cornea, or the back of the eye, the retina, that could result in loss of vision or need for additional surgeries. But that being said, you know, cataract surgery is one of the most commonly performed procedures, and one of the most effective of surgical options that we offer to our patients. But it's very much a personal, individualized decision as to when you need to proceed with cataract surgery. It's not an emergency. It's all about quality of life. And you want to wait until you feel that your activities of daily living are being impacted. So at the time of cataract surgery, we make a very small incision to remove the cloudy lens. We numb up the eye completely with topical anesthetic drops. We make small incisions to give an additional lidocaine and epinephrine to completely anesthetize the eye. We use minimal sedation, and patients usually are very comfortable just laying flat and looking at the microscope lights ahead of them. The surgery itself takes about 15 minutes or so, but there's a lot of prep work before and afterwards. But we get the eye patient very comfortable, and we numb up the eye completely with numbing drops and anesthetics into the eye. We make a very small incision, about a 2 millimeter incision in the clear cornea, and we're able to remove the lens using phacoemulsification. That's that ultrasound machine and technique that was pioneered by Dr. Charles Steinert, as I'd mentioned at the beginning of my talk. And when we take out the cloudy lens, we like to put in an artificial lens implant or intraocular lens. And this is to obviate the need for the very thick Coke bottle glasses that perhaps your grandparents, you may have seen before the early 70s. We didn't routinely start using intraocular lens implants. And before this era, after removal of a cataract, patients had to wear very thick lenses in terms of their glasses. But really, since the 70s on, we're routinely putting intraocular lens implants at the time of cataract surgery. And these can be folded and placed through a 2 millimeter incision into the capsular bag. The remnants of the clear, it's basically positioned stably for life, I tell my patients. When you go to your ophthalmologist and, or referred for cataract surgery, you may go to a practice that gives you many options to the types of intraocular lenses. But I'm very conservative in terms of the types of lens implants that I use in my general practice, as well as what I would recommend for patients with myotonic dystrophy. I'd say in my practice, and I don't see many patients with myotonic dystrophy. I see a couple a year. But for the vast majority of my patients, I recommend the standard monofocal intraocular lens. And that lens is good for your distance vision. So I tell my patients it's all about quality of vision. And I want your vision for distance to be as good as possible so that you have a good depth perception. You're able to walk, hopefully be able to drive without much of a need for glasses. As you get older, depth perception is very important. So, if you have both eyes good for distance, you'll have good depth perception. That's what I advocate for my patients. Both of my parents had a cataract surgery. They both got the monofocal lens implants that are good for their distance vision. I tell my patients after cataract surgery with a monofocal lens implant, you're going to need reading glasses. You may even need a thin pair of bifocals to fine-tune the results to be able to see the high-definition television or the small street signs. But 90% of my patients, I advocate for the monofocal lens, a standard lens implant. This is the lens implant that's covered by medical insurance and Medicare and most standard insurances. At the time of at the time of your evaluation with your cataract surgeon, they're going to get a bunch of measurements to determine the power of the lens implant that's required. They're going to measure the length of the eye as well as the corneal curvature. These are the two main variables that help a surgeon pick the appropriate power intraocular lens. Some patients may have a lot of astigmatism at the level of the cornea. So astigmatism is when the cornea is not perfectly round. It's steep in one direction and flatter in another. And some of you may be familiar with the amount of astigmatism in your glasses. Sometimes that astigmatism in the glasses may correlate to the amount that's on the cornea. But we have to get all these measurements to accurately determine how much astigmatism your cornea has. This toric intraocular lens corrects for astigmatism. And it is a good lens in the sense that it corrects for astigmatism without compromising quality of vision. So I'm a big advocate of quality of vision, and the monofocal lens and the toric lens, they give you the best quality of vision for distance. And that's what I advocate to all my patients. There are a subset of my patients that want both distance, intermediate, and near vision. And there is a multifocal lens options that are available to cataract surgeons that give a good range of vision. But I tell my patients they give a good range of vision, but they compromise quality of vision. There's about a 30% reduction in contrast sensitivity with the multifocal lenses. Patients with the multifocal lenses, they may have a higher incidence of glare and halos, around pinpoint sources of light. Patients may notice this when they're driving. And I don't recommend the multifocal lenses to pilots or patients that need a commercial driver's license because of these aberrations in the quality of vision. I try to dissuade my general cataract population from getting the multifocal intraocular lens because it gives you a good range of vision, but it compromises quality of vision. And you also have a higher incidence of glare and halos around pinpoint sources of light. Keep in mind, there are additional expenses out of pocket that you'll have to pay for the toric intraocular lens, as well as the multifocal intraocular lenses. So there are extra payments that you'll have to make to your ophthalmologist in the surgery center. But regardless of the extra costs, I'm just not a big advocate of multifocal intraocular lenses in my general cataract patients. And given the different eye manifestations of myotonic dystrophy, I would be very cautious about its use in patients with myotonic dystrophy. Patients with myotonic dystrophy have also been reported to have some pigmentary changes in the retina. This is a fundoscopic images showing the optic nerve and the blood vessels that emanate from the optic nerve. And right in the center of each photograph is the macula, the central part of the retina. And there's some pigmentary changes that are evident in this patient with myotonic dystrophy. These pigmentary changes can also be in the peripheral part of the retina. So I was recruited to UT Southwestern 20 years ago to implement new types of corneal transplant procedures for this entity called Fuchs endothelial corneal dystrophy. Many of you may never have heard of this disease entity, but it's very common. About 4% of whites over the age of 40 have some form of Fuchs dystrophy. It's a common age-related disease of the cornea. For unknown reasons, there's a strong female bias, a 3-to-1 female bias. And taking a little deeper dive into the layers of the cornea. So on the surface is the corneal epithelium. That's the outside world. But if you were to go to the inner layer of the cornea, you see the endothelium. The endothelium is the innermost layer of the cornea. I describe this layer as the pump cells to my patients. These pump cells are important because they maintain the fluid balance within the stroma. The stroma is a substance, main substance of the cornea. We all lose these cells, the endothelial cells, these pump cells, basically the day we're born. So it's an aging change, loss of these endothelial cells. But in patients with Fuchs dystrophy, there's an accelerated loss of these pump cells. And that can result in swelling of the cornea and scarring. And it's hard to depict by slit lamp photos, but on the far right is a patient of mine with Fuchs dystrophy. And there I'm kind of using the slit beam to kind of get a cross section through the cornea. So that's that first light reflex. But the innermost layer, there's a little bit of a pigment and haze. That's probably a patient with mild or moderate Fuchs corneal endothelial dystrophy. Patients with Fuchs dystrophy, they may notice glare. And this is a symptom that I had mentioned that one can have also from cataract. So it's important for your eye doctor to try to figure out if you're having glare, is it because of a cataract or is it potentially because of changes to the cornea? There are no medical treatments for this age-related corneal disease called Fuchs dystrophy, and it's the leading indication for corneal transplantation in the United States and developed world. So on the far left, it's also a slit lamp photo. We're using the light to create a red reflex, similar to what you may notice when you take a photo with a flash and you'll see the red eye. That's the same phenomenon of light being transmitted through the cornea into the eye, being reflected from the orange retina fundus, and you're able to see this red reflex. But you might be able to see those punctate little changes in the red reflex on the far left, and those are the earliest changes in the innermost layer of the cornea, the endothelium, and its underlying basement membrane called Decimase membrane, but you see these punctate little dots that we call guttae. And we can see these changes with that slit lamp microscope that is used to examine the front and back structures of the eye. In the middle and on the far right is the natural disease progression in a small minority of patients with Fuchs. Not everyone with Fuchs will develop significant eye disease. So I want to put that in perspective. Even though 4% of whites may have some findings of Fuchs, it's really a small minority of patients with Fuchs that actually go on to develop the swelling and the changes that are shown in the middle or the far right picture that impacts the transparency of the cornea and impacts quality of vision and visual acuity. So a few years back, I examined a cohort of patients with myotonic dystrophy type 1. These were patients that were being followed in the cardiomyopathy clinic at UT Southwestern. And we examined 13. And about 6 of them had findings of Fuchs dystrophy. And like I said, 4% of the general population would be expected to have Fuchs dystrophy. But the fact that almost 46% of patients with myotonic dystrophy type 1 had this entity helped establish that this is an eye finding that's associated with myotonic dystrophy. And on the far right, there are special microscopes that can be used to look at that inner layer of the cornea. They're showing the cells that are dropped out, as well as those dark spots called guttae that are better visualized using a specular microscope. That's a modality that may be available at your eye doctor's clinic. And, we're able to examine a corneal specimen from a patient with Fuchs dystrophy with an underlying diagnosis of myotonic dystrophy type 1. And those blue dots are, that's called the DAPI staining of the nuclei, but basically that inner layer of the cornea was examined from a myotonic dystrophy type 1 patient, and using a RNA probe that's complementary to CUG repeat RNA, we're able to see accumulations of CUG repeat RNA as foci in the corneal endothelium tissue samples of this patient. And some of you are very knowledgeable, I know, about the molecular basis of myotonic dystrophy type 1. And this phenomenon was originally described by Dr. Charles Thornton in the skeletal muscle of affected individuals. And this repeat RNA, it accumulates in affected tissues, including the cornea, and it binds with these splicing factors called MBNL1 and 2, and it results in missplicing. And this phenomenon that's seen in heart and muscle, we showed it to be the case in the corneal endothelium of patients with Fuchs dystrophy and an underlying diagnosis of myotonic dystrophy type 1 with the DMPK triplet repeat expansion. So as I've mentioned, I was recruited to UT Southwestern 20 years ago to implement new types of corneal transplant procedures for Fuchs dystrophy, this common age-related corneal disease. And 20 years ago, we only had one option for corneal transplantation, and that was to remove the entire full thickness of the cornea. But over the last 15 to 20 years, our surgical treatments and the type of corneal transplant surgery we do has become much less invasive. And this has given many advantages to our patients' recovery and quality of vision after corneal transplantation. So a vast majority of patients with Fuchs dystrophy, where just the inner layer of the cornea is diseased, we're able to go in through a relatively small incision, about a 4 or 5 millimeter incision, remove that inner layer of the cornea, and transplant just the inner layer of the cornea using donor tissue that's been prepared at the eye bank. So now we're able to do more selective corneal transplant surgery, where rather than transplanting the full thickness or all the layers of the cornea, we're able to more selectively remove just the diseased layer, the inner layer called the endothelium. That's that layer that's critical for the pump function and maintenance of the fluid balance and clarity of the cornea. We're able to transplant that diseased tissue with tissue from the eye bank from patients that have passed, but they've donated their eyes and corneas for transplantation. So my advice to patients with myotonic dystrophy is to start getting annual eye exams. Try to establish yourself with a good comprehensive ophthalmologist. I think certain aspects are more commonly found in myotonic dystrophy patients, and these would be my recommendations. Ptosis or droopy eyelids are not uncommon. But I would be conservative about advocating surgical repair, trying to lift the eyelids. You should be very cautious because I wouldn't want the corneas to be exposed and be more prone to dryness. I do feel that patients with myotonic dystrophy, their blink may not be as robust in terms of complete closure of the eyelids, or the rate of blinking may be less than other individuals. I think additional studies need to be done on this, but I would be conservative, because if the eyelids are raised and you have incomplete blink or incomplete closure, that can really exacerbate dry eye. Patients with even mild dry eye, and I think this approach is something that would apply to most of the group in this audience. I like the artificial tears that are preservative-free. They come in these univials. Once you open the vial, it's good for a day, and then you should toss it. You can keep it in a small, clean Ziploc bag during that day. But these artificial tears in these individual vials, you want to use up within a day. And usually you can get at least 3 or 4 drops out of each of these vials. And I would stick with a good brand, or preservative-free tears from a big vendor like Walmart or Costco. I would also advocate patients with dry eye to use a hot compress, a clean hot washcloth that's been microwaved such that it's hot, but you don't want it to be so hot that it scalds your skin. But the heat applied to your eyelids shut will help with the oil glands that are at the lid margin. Those oil glands are very important because they create lipids that coat the tear film. And if you do this combination of artificial tears and a hot compress, this is a mainstay of treatments for patients with a dry eye, which is a very common age-related change, especially in women as they get older. I think in your 30s or 40s, that's the time to really start monitoring for cataracts. And even if you have an early cataract, that's not something to get alarmed about. It's just something that you need to be aware of and followed. So even if you've been told that you have a cataracts in your 30s or 40s, wait until you feel that the quality of vision is being impacted. You're reading and driving, and at that point, you need to have a good discussion with your ophthalmologist to see if they feel that you have enough cataract changes to warrant the risks of cataract surgery. But modern cataract surgery is very safe and very effective. So at the appropriate time, I think you'll have a good option for your cataracts. On these annual visits, it's important for them to monitor your eye pressure, and they can also check for any corneal changes, namely Fuchs endothelial corneal dystrophy. And as I mentioned, only a small subset of patients with Fuchs dystrophy actually go on to needing corneal transplantation. It's really reserved for the more advanced cases. Yeah, I think the Myotonic Dystrophy Foundation does a great job, and patients and families, they know it's important to bring up your underlying diagnosis with any surgeon that you may interact with and any anesthesiologist that you may interact with, and just make them aware of your diagnosis. In the community, your ophthalmologist and or anesthesiologist may not have expertise as much as you do about the potential risks related to anesthesia. But be assured that we only use minimal sedation for cataract surgery. I typically use just a little bit of Versed to help my patients relax. It's a benzodiazepine, a very low dose. That shouldn't interfere with respiratory function or swallowing, but those are potential risks. And we completely numb up the eye with just eye drops and medicine anesthetic drops into the eye. And generally, there's no discomfort during the surgery, and only minimal discomfort or scratchiness after cataract surgery. If you need a more involved surgery, like corneal transplant surgery, that's where you may need additional sedation. You may need a local anesthetic block called a periobulbar block or retrobulbar block or subtenon's block, and in some instances, even a general anesthetic. And this is where, the guidelines that are on the Myotonic Dystrophy Foundation website would be very useful as a resource for your doctors if they're not aware of the potential risks related to myotonic dystrophy. But I think this group is very savvy. I think the anesthetic risks are mainly related to sedation and its effect on breathing and swallowing. And the GI system can slow down even more with opioids. And the myotonia and the heart rhythm needs to be monitored closely for arrhythmia during prolonged surgery or general anesthetics. So as you can see, I have an interest in Fuchs endothelial corneal dystrophy, and our observation that myotonic dystrophy patients are at an increased risk for Fuchs dystrophy has sparked an interest for me to learn more about the molecular genetic basis of eye disease in patients with myotonic dystrophy. And this is my plug to reach out to me if you or your family member will be undergoing cataract surgery or corneal surgery. We'd love to potentially enroll you into one of our ongoing studies on myotonic dystrophy eye disease. These are my references. And at this point, I'd be happy to take any questions.
Thank you. Thank you so much for that informative presentation, Dr. Mootha. We're, as you mentioned, now going to transition into the Q&A portion of today's webinar. As a reminder, we ask that you use the Q&A function to ask your questions, and they will be sent directly to our experts. We will do our best to answer as many questions as we can over the next 15 minutes. And you can go ahead and submit your questions whenever you'd like, or submit them anonymously if you prefer. So now that the floor is open to questions, I have a couple questions here from the audience already, and feel free to keep them coming. But you mentioned, and I appreciate you answered some of these questions as in your presentation, specifically around dry eyes and ways to counteract them. But we have one question here about neuro-ophthalmology. So a community member who enjoys their ophthalmologist and thinks they do a good job supporting them, but knows nearby there's a hospital that has a neuro-ophthalmology practice. And a lot of times in the DM community, we're encouraged to see neuromuscular specialists and other neurospecialists. So can you explain the difference between the two, and should our community consider going to a neuro-ophthalmologist or stick with their general ophthalmologist?
Well, I think you may want to continue your relationship with your ophthalmologist, because especially if you have a cataract, because it's your ophthalmologist, comprehensive or corneal specialist that would do cataract surgery. So I think it's important to have an established ophthalmologist, and they can be a general ophthalmologist in your community, and have annual exams by them. Neuro-ophthalmologists are ophthalmologists, but they've taken an additional year or two of specialized training. So they are experts with neuro-ophthalmological aspects, neurology, ophthalmology aspects, and how they affect the eye. They don't do cataract surgery or corneal transplant surgery, but they are experts with assessing, eye movement disorders that you may have. It would, if you have ophthalmoplegia or problems moving your eyes, or if you have problems with your saccades, rapid eye movements from right to left, or if you have double vision. These are the types of complaints where an assessment by a neuro-ophthalmologist would be very useful. It would be rare, but if you had double vision because of the extraocular muscles being weak, there are special glasses called prism glasses that can be of help. So I think the neuro-ophthalmologist would be great if you have eye movement disorders. And I would continue to see your comprehensive ophthalmologist for your general eye care, including cataracts.
And this is another question we got from a couple different community members about the recurrence of cataracts. Someone who may have had cataract surgery 7 years ago at a young age, and then having laser treatments afterwards. Will this likely keep recurring, or does that involve an additional level of care?
No, I think after cataract surgery, we take out the cloudy lens and we put in that lens implant in that clear capsular bag. And it's very common for that clear capsular bag to get cloudy over time. And this can happen in all individuals that have had cataract surgery. And that's called a secondary cataract or after cataract or posterior capsule opacity is the technical term. And it's not uncommon. And this can happen at any time point after cataract surgery. But if you develop a secondary cataract, you need a laser that's done in the clinic, and that's done in the comprehensive ophthalmologist clinic or whoever did your cataract surgery. It's called a YAG capsulotomy. So we make a small opening, and that's done in the clinic with just eye drops, and it takes literally 2 or 3 minutes. But once you have that opening in the posterior capsule for the secondary cataract, that entity is taken care of indefinitely. It won't come back.
Great. And a one follow-up question to that is it dangerous to have numerous laser treatments on your eyes?
Well, I think you want to be a minimalist and not have unnecessary procedures if you have, just generally speaking. So, in terms of laser procedures, I would probably discourage LASIK or PRK. That's treatments for myopia or nearsightedness. Other lasers that are used are for glaucoma, and if it's indicated, you should get those lasers for glaucoma. The most common laser procedures is after cataract, and I don't think one should hesitate if there's an opacity, an after cataract that needs to be cleared. So those are the most commonly performed lasers in ophthalmology, and most of them are safe and effective, but you want to be a minimalist and just have the laser procedures that are indicated.
Great. Here's a question about ophthalmology versus
Optometry?
optometry.
Yeah.
Thank you.
No,
And
I think, yeah. And the differences in whom you should see. I think ophthalmologists, they're eye doctors, but they also do surgery. Optometrists, they're eye doctors, but they typically don't do surgery except for potentially minor laser procedures. So, I have a bias at being an ophthalmologist and knowing that myotonic dystrophy patients may ultimately go on to needing cataract surgery. It may make sense to establish care with an ophthalmologist and see them on an annual basis. That being said, there may be some remote areas where access to ophthalmologists may not be good, and there are very competent, well-trained optometrists that can do your annual eye exams and potentially refer you to an ophthalmologist or a surgeon when you reach a point where you may benefit from one of these surgeries.
And have you seen styes to be a problem in DM1, especially with folks who may be experiencing droopy eyes?
I'm not sure if I have enough experience to have made that observation in my practice. Styes are very common. That's when those oil glands that I was talking about at the lid margin, they can get clogged up and develop a stye or chalazion. I don't know of a correlation between myogenic ptosis and styes, but the treatments that I recommended for dry eye are applicable if you think you have a stye, a hot compress, but I would do it probably twice a day for 10 minutes, a clean hot washcloth for about 10 minutes twice a day. And an omega-3 supplement, fish oil or flaxseed oil, may help with the oil gland quality and maybe some inflammatory changes. So I tell my patients with a stye to try to use an omega-3 supplement, a gram a day for a couple of weeks to try to help the stye resolve. In rare circumstances, that the stye needs to be drained surgically.
Okay, thank you. And here's a question about chronic iritis. I don't know if I said that correctly.
Iritis.
Iritis, thank you. And it might be an autoimmune condition, and we know that autoimmune conditions can correlate with DM. So do you see an association between iritis and DM?
I don't know of that association.
So additionally, another syndrome with the eye, you've spoken about how cataracts and Fuchs both might be associated with DM. And we have a community member who has been diagnosed with both of those. And in addition to those, also has pigmentary dispersion syndrome. Is PDS associated with DM1?
I'm not aware of that association, as well.
Okay. And what about floaters? We know that many people experience floaters, but do you notice them more with your DM patients?
I can't explain why they would be more common in patients with myotonic dystrophy. There's a jelly inside of the eye called the vitreous. And all of us probably in the early middle age, starting in the 40s, that vitreous jelly becomes more fluid. And as this vitreous liquefies, patients can notice floaters because the transparency of the vitreous is changing with age. So all of us will develop floaters with aging. But I can't explain why it would be more common in patients with myotonic dystrophy.
You. So someone with DM1 has been struggling with the comfort of their contact lenses in the years when previously, when wearing them throughout most of their life, they did not. Does this have to do with DM or do you have any recommendations?
You had mentioned optometrist versus ophthalmologist. I think for your contact lens care and glasses, I think optometrists are probably more focused on providing these types of services. So hopefully this patient has a good optometrist and has checked the fit of the contact. And there are a lot of rapid developments in the materials and design of contact lenses, which I don't follow. We have good optometrists here at UT Southwestern. But things to consider in the context of myotonic dystrophy is whether or not they have underlying dry eye, as well as the lid position and how it may impact the fit of the contact lens. So those are the factors and variables that I think this individual needs to have with their optometrist or ophthalmologist, whomever they're seeing for their contact lens fittings.
We have a question here about vertigo, and they share that they know vertigo is often caused by the inner ear and not the eyes, and their doctor they're seeing says it's classic vertigo, but it's not going away as quickly as they would expect it to with treatments, and we're wondering if it can be connected to DM or any issues with vision.
This may be a topic for a neuro-ophthalmologist to weigh in on. I don't know of the association of vertigo and myotonic dystrophy. I certainly don't have any experience with this entity in my general practice as well. Generally we think of inner ear. We know that myotonic dystrophy can affect the central nervous system, so there could be a potential connection or link, but that would be beyond the scope of my practice or funded knowledge.
Of course. Earlier, you spoke about Christmas tree cataracts and showed pictures of them as well. And we know that a Christmas tree cataract can be a diagnostic tool for DM. And so some community members have felt frustration that their ophthalmologists did not refer them to neurologists. Can you speak about how in the ophthalmology field that is used as a diagnostic tool and how someone may go about encouraging their ophthalmologist to get that referral?
Yeah, I think we need better awareness amongst ophthalmologists to remind them of this very important, type of cataract that can be diagnostic for myotonic dystrophy. That being said, it's a spectrum of changes in the crystalline lens, and not all patients with myotonic dystrophy, including the one I showed, had that classic Christmas tree appearance. But yes, I think if patients without an underlying diagnosis of myotonic dystrophy are seen, and there's better awareness in the community in terms of ophthalmologists in our field that this type of cataract can really help make the diagnosis, that could be very beneficial for our patients and their families. So yes, I think we need to promote more awareness of this peculiar type of cataract and the important association.
We'll just ask, we have time for just a couple more questions. So you spoke earlier a little bit about surgery for droopy eyes. And there's a question here about an age limit or potential challenges based on age for getting that surgery for someone with DM, if it's applicable for younger people, older people, or anyone in between.
Yeah, overall, I would be very conservative because of the potential for corneal exposure. For patients that are going to consider ptosis repair, they should see a subspecialist as well. There are comprehensive ophthalmologists that do eyelid surgery that's more commonly seen with age-related ptosis and of the eyelid and brow. But there are subspecialists called oculoplastic surgeons that are ophthalmologists and have had additional training in eyelid surgery and surgery around the eyes. So you should really see a qualified oculoplastic surgeon, and also remind them of your diagnosis of myotonic dystrophy. And they may not have much experience with myotonic dystrophy, but there are other myogenic forms of ptosis. So I think it needs to be a very thoughtful discussion with a oculoplastic surgeon. But generally speaking, I would be very conservative as to avoid corneal exposure.
Thank you. And here's a question asking about correlations between the abnormal saccadic velocity or other conditions as it relates to sleep issues in DM.
Yeah, I think this audience can educate me about the sleep disturbances in myotonic dystrophy. I don't know the association between abnormalities with sleep and the saccades. I know different types of saccades have been reported, abnormalities in saccades, including intranuclear ophthalmoplegia, where, like I said, when patients are moving their eyes rapidly to the right and left, there's an inability to move one eye normally. But I don't know if it's association with sleep.
And one last question, it's actually specifically from a community member in your area in Dallas, who's looking for an ophthalmologist, but is struggling to get into UT Southwestern. But I'm wondering if you can answer this for the rest of the community around the country and world, is if you have any recommendations for finding an ophthalmologist who knows about DM1, or what the first thing you should tell your ophthalmologist as a new patient with DM1 is.
I think most comprehensive ophthalmologists should be able to care for your eye, but it is important for you to be advocates. And MDF, I know all of you and your families are advocates, and you will be teaching your doctors about your condition, and you should bring up your diagnosis with your ophthalmologist, and that way they're going to hone in on the findings that we discussed today. But yeah, I think just continue to be advocates. I know your organization does a great job advocating for patients and families. And as a individual going to the eye clinic, just make it clear to your eye doctor that you have this entity and want to be followed by them on a regular basis.
Great. And one last question for you here, and it has some abbreviations, so I'm hoping you may know better than me what they mean, but can you comment on DSO in DM patients for Fuchs, if there's any data, and the experience of DMEK in DM patients? Is there any difference with respect to graft success and survival?
Yeah, these abbreviations are for different types of corneal transplant procedures. And as I mentioned in that overview slide, we don't have to replace the entire cornea anymore. We're able to just replace the inner layer of the cornea. So patients with Fuchs dystrophy, probably the procedure of choice these days is that DMEK procedure, Descemet's membrane endothelial keratoplasty, where we remove just the disease layer and we transplant tissue from the eye bank, that same healthy tissue layer from a donor from the eye bank. So DMEK, or Descemet's membrane endothelial keratoplasty, I think has become the standard of care for patients with Fuchs endothelial corneal dystrophy. And that's the type of disorder that myotonic dystrophy patients can develop. DSO is Descemet stripping only, where we remove the Descemet's centrally and hope that the peripheral healthier endothelial cells migrate in. And less is known about myotonic dystrophy and DSO. And I think DSO, only a small amount of the central cornea can be affected for it to be considered by your corneal transplant surgeon. So that is an emerging procedure. It may help a very small subset of our patients with Fuchs dystrophy. And by extrapolation, I think it may only help a small subset of patients with Fuchs dystrophy and myotonic dystrophy.
Awesome. Well, seeing as we're already a couple minutes past the hour, I want to take this time to thank all of our attendees for your participation, and thank you again, Dr. Mootha, for presenting this amazing Ask the Expert webinar. As a reminder to everyone here, this webinar was recorded and will be sent out within the next week or even later today for you to review and share with the community. After the webinar ends, you'll be provided with an option to take a short survey about today's program. We greatly appreciate you taking the time to provide us feedback. Lastly, if this program spoke to you, please consider showing your appreciation by making a donation via our website. You can also get more involved by joining the Myotonic Dystrophy Family Registry. Thank you all for joining today's webinar, and we'll see you next time.